Thanks, everyone, for continuing to pay attention. It's been a very informative day. I'm going to actually kind of completely swing the pendulum to a purely clinical talk and talk about kind of the MD Anderson single institution perspective on the role of chemoradiation in advanced and unresectable cholangiocarcinoma. So everyone in this room knows that the majority of patients with cholangiocarcinoma present with advanced or unresectable disease. Historically, and even through today, chemotherapy has been the mainstay of treatment, with obviously gemcitabine and platinum as being the backbone for first-line therapy. As far as the role of localized chemoradiation, however, the role of radiation, the timing of the radiation, all of that has been a little bit of a gray area. So our primary objectives at looking at our experience with chemoradiation was to determine first-line chemotherapy that's given in the unresectable setting at our institution, as well as the percentage of patients that went on to receive chemoradiation thereafter. Other things that we were trying to measure included disease response with first-line therapy, as well as the median number of chemotherapy cycles that were given prior to moving on to chemoradiation, the duration of control after chemoradiation, and then progression-free survival and overall survival with or without chemoradiation from the time of diagnosis. So as I already said, this is a single institution retrospective chart review, so we admit that there is an inherent bias in that. This included our population of unresectable cholangiocarcinomas from 2009 through July of 2013. And basically, the patients that we included were patients that had the diagnosis and had received treatment and follow-up at our institution for us to have the most complete clinical data. We excluded patients who had other forms of liver-directed therapy, including radioembolization, chemoembolization, as well as mixed histology tumors and any other malignancies that were concurrent. And we used essentially summary statistics to describe the population, as well as Pearson's chi-squared test, or t-test, to determine differences between groups. Our survival analyses were with Kaplan-Meiers, and univariate Cox proportional hazards regression looked at each individual variable and its relation to overall survival and progression-free survival. So this included a total of 114 patients. The median age was 63, with, as you can see, a pretty broad range of ages. It was about a 50-50 split in terms of gender distribution. And similar to what we've heard, I think, in some of the other talks today, the majority of the patients included were intrahepatic cholangiocarcinomas, about 62%. 24% were hilar tumors, and 14% were extrahepatic. Not surprisingly, the majority of our patients received a gemcitabine plus platinum chemotherapy in the frontline setting, either cisplatin or oxaliplatin. You can see here at the chart that the majority received gemcitabine plus cisplatin. Some of the other combinations included gemcitabine with cisplatin with the addition of erlotinib, single agent gemcitabine in a small percentage of patients, as well as the gemcitabine-capecitabine combination that we heard about yesterday. And some patients received chemoradiation up front without initial chemotherapy. That was 16.7% of patients. Similar to results that have been already published, 75% of our patients had disease control with first-line therapy at restaging with the first CT scan. That includes partial response, complete response, and stable disease. You can see the breakdown there, with 35% of patients having a partial response. 25% had progressive disease at first restaging. Out of these patients, 65% of patients went on to receive chemoradiation. 7% had radiation alone without any chemosensitization. The median number of chemotherapy cycles that were given prior to chemoradiation was 6, and the median duration of chemoradiation control was 6.4 months, and you can see that there is a very broad range there. The median dose of radiation given was 50.4 gray, as would be expected. And 62% of patients had disease control, either response or stable disease, at the first scan after chemoradiation. So this kind of breaks it down by the no chemoradiation and chemoradiation groups. As you can see, the 40 patients had no chemoradiation, 74 had chemoradiation. The median progression-free survivals and overall survivals are listed there, with a chemoradiation arm having a median overall survival of 29.4 months compared to 22.4 months in the no chemoradiation arm. We then stratify those patients, or looked at the difference in patients who basically had response or stable disease with first-line therapy. And so of the patients who received chemoradiation, 62 of them had disease control on first-line treatment. And in those patients, median progression-free survival was 15.7 months, and median overall survival was 32 months. And then that's compared with chemoradiation patients who had progression on first-line treatment, which was a small number, 12, who had a median progression-free survival of 4.2 months and overall survival of 6.9 months. These are the progression-free survival Kaplan-Meier curves, and this is just breaking it down by no chemoradiation versus chemoradiation. And you can see the p-value there is 0.105. This is that progression-free survival curve when we break it down further into patients who received chemoradiation with control on first-line therapy versus versus progression on first-line therapy. And you can see at that point that there is a separation of these curves, with the chemoradiation arm with first-line treatment disease control doing better significantly. P-value is less than 0.001. Looking at overall survival, similar types of findings in the sense of when we stratify it by treatment response, but this is the overall group, no radiation versus chemoradiation, with a p-value of 0.005. And this is that separation, again, when you look at patients who had progression versus disease control with first-line treatment. These are just some pictures that our radiation oncology colleagues provided us. This is an example of a 14-centimeter intrahepatic cholangiocarcinoma who was given radiation. And these are the fields that were designed, and I'm not a radiation physicist, but basically what you see here is that in the bed, the maximum dose that was given was actually 100 gray. More peripherally, there was 75 gray. Stomach received a total dose or max dose of 55 gray. So our radiation oncology colleagues always talk to us a little bit about, their term is turning up the dial, and about the fact that the liver seems to tolerate higher doses of radiation, and depending on the location of these tumors, that we should be more strategic about the dose escalation that we give in terms of radiation. And this is just one example of of what they did there. This is our proton therapy technique, again with a unresectable tumor. You'll notice that this tumor is very far removed from the bowel, which obviously is a very important factor in radiating these patients. And that was the response after 2 months after completion of proton therapy. So this is just some graphs that our radiation team has looked at, looking at the effect of the radiation dose. And what they found is in patients who in the tumor bed received a total of over 85 gray, those patients had improvement in local control as well as overall survival. Most of these people, when they do quote-unquote recur, it is outside of the radiation field. So, we've been talking with our radiation group about what other questions we can be asking, since we've now looked retrospectively. And at MD Anderson, I think the general feeling is there is a role for radiation in some patients with unresectable cholangiocarcinoma. And so the PharmD who actually put this abstract together, and who unfortunately could not be here to present today, is now going to go back and look to see what kind of molecular profiling we have on these patients and their tumors, to see if there's any sort of a profile for radiosensitivity, chemosensitivity that comes out. The other obvious questions include, is there a best chemosensitizer? Should it always be capecitabine? Do we need capecitabine? As well as, what is the quote-unquote best radiation technique? We have a lot of different techniques that are out there. Proton therapy gets a lot of advertising, but we don't know that it's actually the quote-unquote better technique. And so looking at these different modalities of IMRT, proton, stereotactic radiation, and then of course the question of, is this better than chemotherapy? Is that going to be, is it going to work hand in hand with chemotherapy? Does it supplant chemotherapy? So the NRG, I think Milind referred to this last night. The NRG has designed a phase 3 study, which is a randomized study that involves unresectable cholangiocarcinoma patients. They have to have liver-limited disease. no cirrhosis, and up to 2 satellite lesions and tumors up to 12 centimeters or less. And they are planning to stratify these patients based on size of primary tumor as well as the presence or absence of satellite lesions. And these patients are going to receive standard of care gemcitabine and cisplatin. After 3 cycles, they will be restaged and then will be randomized to receiving liver-directed radiation therapy, followed by continuing on with gemcitabine and cisplatin, versus just continuing on with chemotherapy alone. And I think hopefully this might give us a little bit more insight into the role that chemoradiation can play. So in conclusion, our evaluation shows that there may be a role for chemoradiation with some improvements in survival. However, patient selection, we do believe, at least based on this retrospective analysis, is key, with disease control and first-line therapy perhaps being the patient population that would benefit most. Again, I want to thank Jane Rogers, who's our PharmD, who did this, and then as well as our biliary cancer team at MD Anderson for the unresectable population. Thank you very much.
Thanks, Rachna. We'll take one question.
Great, excellent presentation. 2 quick questions. One is, who do you select for chemoradiation versus arterial therapy? I know that wasn't the focus of your talk, but it'd be good for us to know what is offered and what, I know you haven't compared the 2 groups, but it'd be good to know who gets what. And the second question is quick, were these all intrahepatics or was some perihilar? Because you just mentioned unresectable cholangio.
Correct. So if about 60, close to 65% were intrahepatics. Those are the majority of the patients, I would say, that we end up sending to radiation. Gotcha. And then as far as arterial embolization, I mean, I would say, and this is probably just an institutional bias, that we don't do a whole lot of arterial embolization for our cholangiocarcinoma patients. As far as who we decide to send to chemoradiation, I mean, we have, a very big multidisciplinary conversation about that with our guys, including interventional radiology and radiation oncology. Our patients who seem to have chemo-responsive disease and who have tumors that would be amenable to these more definitive doses that our radiation guys are talking about are the ones that I would say that we think about the chemoradiation playing a bigger component of their care.
So we find that one of the causes of mortality, for instance, is hepatic vein obstruction.
Mm-hmm. No, the data was good.
Yeah, and I mean, our radiation guys kind of say that a lot of these patients end up basically dying from liver failure, and so that idea of that local control may change some of that.
It's just that those tumors looked large, and that's a huge radiation field to cover. I understand if it's a smaller tumor, maybe right at the hepatic vein confluence, but for a tumor that involves the entire left liver or an extended, left, that's a lot of radiation.
It is, and I mean that's how they determine. I mean, when they're mapping it, they determine what that maximum dose is and where the bowel is. We've actually, I mean, Milind has talked about this previously. I don't think at this meeting, but we've worked with our surgical oncology colleagues and have created this program of involving an alloderm spacer, where our surgeons go in and they basically put in a spacer to sweep the bowel out of the way a little bit so that they can increase the dose of the radiation safely. So I mean, we try to kind of work hand in hand to give that maximum tolerated dose, if you want to call it that.
Thanks, Rachna. Okay. So
Marion asked one. So sorry. Marion asked one quick question.
Is this a multi-institutional trial, or is this solely at MD Anderson?
The NRG one. This is multi-institution. Okay. It's through the radiation cooperative group.
Okay, and it probably should be announced somehow on our side if we can get the PI to give the patient-friendly version. Thanks.
Sure.
Okay, great. So now we'll have